Welcome to the How to Be Informed on Class B's webinar. Thank you for joining us today. I'm Alicia Couchman, Director of Education at the Curry Center. We have over 400 participants registered for this webinar from across the United States. Today's session is being recorded and will be archived on our website. Please look out for an email announcing when it has become available in 2 to 3 weeks. All participants have been placed on mute in order to preserve the quality of the recording. If you have questions or comments during the webinar, please feel free to share them in the Q&A chat box. The faculty will address the questions during the Q&A period at the end of the presentation as time allows. This webinar is produced by the Curry International Tuberculosis Center, which is part of the University of California, San Francisco. Our office is located in Berkeley, California. The Curry Center is one of 4 TB Centers of Excellence for Training, Education, and Medical Consultation. We cover the western region of the United States, which is shown in purple on the map. Our region consists of 17 jurisdictions and also includes the U.S. Pacific Island territories. This project was funded by the CDC's Cooperative Agreement and is a project of the University of California, San Francisco. The Curry Center is accredited by the ACCME to provide continuing medical education for physicians. The Curry Center is also an approved provider of a continuing education by the California State Board of Registered Nurses. This webinar is approved for a total of 1.5 continuing education contact hours. To receive CEUs, you must register for the webinar, participate in the entire webinar, and complete the online evaluation. The evaluation link will be emailed to all registered participants immediately following the webinar. We ask that you complete it within 1 week. If any individuals or group members have not pre-registered, please click on the link provided in the chat box to receive an evaluation. Today's faculty have all signed a declaration of disclosure and have indicated they have nothing to disclose. Additional information can be found in our online materials folder. Now it is my great pleasure to introduce today's facilitator, Sherry Stafford. Sherry has been the nurse coordinator for Arizona State's TB program since 2012. She started in her career as a floor nurse on Johns Hopkins infectious disease floor while obtaining her master's in public health and community health nursing. Prior to moving to Arizona, she lived and worked in Nigeria, Liberia, Nepal, and the Philippines. Welcome, Sherry.
Thanks, Alicia. Next slide. So you can see on this slide what our 2 main learning objectives are for today. Next slide. Next slide. Thank you. So as you can see, our agenda is very full. We actually have 3 different presentations that are 20 minutes each. So if you could hold all your questions until the end, actually what you can do is you don't have to hold your questions. Go ahead and put it in the Q&A chat box down at the very bottom. You'll see it says Q&A next to the chat box. So any questions you have that come up, just put it in there and we'll answer them at the end of all 3 presentations. Next slide. Okay, so so to ask questions, like I said, just put in the Q&A box and we will address it at the end. And next slide. Okay, so our first presentation is going to be by Amanda Dam and Deborah Lee. That's going to be on the EDN system overview. Amanda Dam is a public health advisor and contractor of Capillary Services on the Migration Health Information Nexus Unit at the Centers for Disease Control and Prevention based in Atlanta, Georgia. Amanda helps provide quality assurance, monitoring, and evaluation of overseas medical data that is transmitted into the electronic disease notification system. She also communicates directly with other federal, state, and local partners regarding health inquiries, activities, and available resources. Deborah Lee has over 20 years of experience in public health work. For the past 14 years, she has worked as an epidemiologist in the Immigrant, Refugee, and Migrant Health Branch of the Division of Global Migration and Quarantine on U.S. immigrant and refugee health concerns. She currently leads the Migration Health Information Nexus Unit, overseeing the electronic disease notification system and the data provided by the U.S. panel physicians into the EDN health partners. Next slide. And then our second presentation will be by Philip Lowenthal. That's going to be on the evaluation of immigrants with B notification for tuberculosis in California. Philip Lowenthal is an epidemiologist with the TB Control Branch at the California Department of Public Health. Prior to working with the California TB Control Program, Phil worked with the California Emerging Infections Program, and with the UC Berkeley School of Public Health with an epidemiologic investigation of waterborne infectious disease and health. Our last presentation will be by Heidi Bim, and she will be doing a case review on Class B1s. Heidi Bim has been the Oregon TB controller and nurse consultant for the past 12 years. She is also a warm line consultant for the Curie International TB Center. Heidi has served on the board of the National TB Controllers Association and was nominated as the 2019 TB Controller of the Year. Previous experience includes work as an infection control practitioner at OHSU and public health nurse focused on communicable diseases in Los Angeles, California. She holds a BSN from Johns Hopkins University and a master's in public health from UCLA. At this time, I'd like to pass the virtual microphone to our first speaker, Amanda Dam.
Thank you, Sherry. I hope that everyone can hear me. Is it good? Perfect. Good afternoon, everyone. Today I'll be presenting on an overview of the EDN system so that you all gain an understanding of how Class B notifications are provided to domestic partners and how that information is collected. Next slide, please. In this presentation, I'll start by discussing background information to share a bit more about our division at CDC and the purpose of our work, information flow of the electronic disease notification system, also known as EDN, features of the EDN system, and the interjurisdictional transfer protocol. Next slide, please. To begin, we are part of the National Center for Emerging and Zoonotic Infectious Diseases in the Centers for Disease Control and Prevention, which is circled in red here. Next slide, please. And more specifically, within this center, we are in the Division of Global Migration and Quarantine, also known as DGMQ. And within this division, we are in the Immigrant, Refugee, and Migrant Health Branch. Next slide, please. And further within the Immigrant, Refugee, and Migrant Health Branch, there are several different teams. I am part of the Migration Health Information Nexus Unit, also known as MINX. And the MINX unit oversees the programmatic and technical aspects of the notification process of overseas medical information and the EDN system. Next slide, please. DGMQ's public health mission, as you can see on the screen here, is to reduce morbidity and mortality among immigrants, refugees, travelers, expatriates, and other globally mobile populations, and to prevent the introduction, transmission, and spread of communicable diseases through regulation, science, research, preparedness, and response. And our division is unique at CDC in that we have regulatory responsibilities. We work under this regulatory authority. Notably, our regulatory authorities stem from 3 acts: the Federal Quarantine Regulations Act of 1798, the Immigration and Nationality Act of 1968, and the Refugee Act of 1980. And so I'll highlight the main purpose of each act here. The Federal Quarantine Regulations Act was originally developed to prevent importation and spread of communicable diseases. The Immigration and Nationality Act has a list of inadmissible conditions, including active TB, and also requires vaccines among US-bound immigrants. And lastly, the Refugee Act prevents and controls infectious diseases at its origin and provides notifications to state and local health departments of refugee arrivals and health conditions that require follow-up. Next slide, please. Some of the Immigrant, Refugee, and Migrant Health Branch, or IRMS, tools that we use to improve immigrant and refugee health include the Department of State medical forms, also known as DS forms. There are 4 main DS forms in use that help provide technical guidance for overseas exams. And these forms include the DS 2054, which is the medical examination for immigrant or refugee applicants, the DS 3030, which is the chest x-ray and classification worksheet, the DS 3026, which is the medical history and physical examination worksheet, and the DS 3025, which is the vaccination documentation worksheet. And these DS forms in turn help improve the quality of panel physician examinations overseas. Additionally, IRM works closely with the Department of State, the Bureau of Population, Refugees and Migration, also known as PRM, and the International Organization for Migration, also known as IOM, to provide presumptive intestinal parasite treatment, anti-malarial treatment, hepatitis B screening, and a vaccination program specifically for refugees. IRM also provides domestic guidance for US-bound immigrants and refugees, as well as arrival notification and overseas examinations via the EDN system. Next slide, please. And so now I'd like to provide an overview of the EDN system. EDN is a centralized electronic reporting system developed in 2008. It notifies state and local health departments of US arrivals, and it's accessible to CDC users, state and local health departments, and screening clinics upon request and approval of EDN system access. EDN collects health information on all immigrants with Class A or B medical conditions and on all refugees. It also collects information related to the vaccination for immigrants and refugees, as well as for anti-malarial and intestinal parasite treatment, specifically for refugees. So far, the notification time range on average has been approximately 8 days post-arrival, from date of arrival to the US to notification date to specific jurisdictions in the US. And EDN has approximately 1,400 users in about 400 jurisdictions throughout the US and US territories. Next slide, please. In this slide, it's going to be a pretty packed with information, so I'm happy to answer questions at the very, very end. But this is meant to explain the information flow from overseas to our US health partners. EDN receives the required overseas medical information by paper and electronic processes. So in the paper process, which is in the green bar at the very top here, first, the immigrant, the individual will go to the panel physician overseas. A second, exams are collected on paper DS forms. Third, these paperwork are collected at the port of entry by US Customs and Border Protection, also known as CBP, and provided to the quarantine station staff upon arrival. EDN Data Entry Center staff enter this paperwork into the EDN system. And fourth, notifications are then sent to local and state health departments for individuals with TB classifications, and TB follow-up is reported back to DGMQ for individuals with those TB classifications. Now, in the electronic process, there are 2 routes through which the EDN system receives information, and this is in the 2 blue bars that you see here towards the bottom of the screen. For immigrant arrivals specifically, First, the immigrant will apply online via the Department of State website, and that information then goes into the e-medical system until they're ready to visit the panel physician. From there, the immigrants will see the panel physicians in an overseas screening where they'll undergo a chest x-ray exam if needed, and the panel physician will then look for this individual in the e-medical system. The medical information from this overseas screening, as well as the chest x-ray image, will be uploaded into the e-medical system. And second, information from the e-medical system is then sent to DGMQ's pre-med staging database, which is a database that houses all information for immigrants regardless of health conditions. And third, immigrants with TB classifications are transmitted from that pre-med staging database to DGMQ's EDN system. And from there, notifications for immigrants diagnosed with TB classifications are sent to local and state health departments. And local and state health departments then complete follow-up information for these immigrant visa applicants via the EDN system. For refugees in the electronic process, which is on the bottom of the screen here in blue, first, the refugee will go to the panel physician overseas. Second, a majority of refugees' paperwork is transmitted through IOM's electronic reporting system called Mimosa. And this information is then sent from Mimosa to DGMQ's PT Plus database, which is a database that houses all information for refugees, regardless of health conditions. And third, the refugees' medical information is transmitted electronically from that PT Plus staging database to DGMQ's electronic disease notification system. And then lastly, notifications are then sent to local and state health departments for all refugee arrivals. And TB follow-up is reported back to CDC for individuals with TB classifications. Next slide, please. The TB follow-up worksheet is used to follow up with patients diagnosed with TB classifications to better and properly treat them. Prior to 2008, the TB follow-up worksheet was completed by quarantine station staff and then sent back to CDC via mail. But presently, there are no more mailings. EDN has a data entry feature for TB follow-up with a more efficient process. We also collaborate with the Division of Tuberculosis Elimination here at CDC for the National TB Program Objectives and Performance Targets, most notably the objective that ensures the completeness of each core EDN system data item reported to CDC, as described in the TB Cooperative Agreement announcement. And this TB follow-up data is then shared with the National TB Indicators Project, also known as NTIP. And so when our users reopen a TB follow-up worksheet that was generated prior to 2018, to make updates, all fields repopulate into the current 2018 form, and the fields that remain blank in the 2018 form will be newer fields that don't have information to pull from the previous version of the TB. Next slide, please. For our EDN system users, for people who request access to the EDN system, they email the MINX unit at mhinx@cdc.gov. And requesters will be required to complete an EDN user agreement and send it back to the MINX unit. US partners involved in health screenings of arrivals in the US and US territories may request access to the EDN system, and it's best used in the Internet Explorer browser. The EDN system is dichotomous for users in the sense that information for arrivals with refugee benefits will be sent to refugee health coordinators users, and information on arrivals with TB classifications gets sent to TB coordinator users. But I would like to note here, as you can see with the little indicated by this asterisk here in the last row in that table, refugee health coordinators also receive notifications for refugees that have TB classifications. Next slide, please. So EDN users receive an email when they receive a new arrival in their jurisdiction or jurisdictions. And the alien list feature displays a list of arrivals in the EDN user's jurisdiction or jurisdictions. This list can be sorted by visa type, TB class, date of arrival, notification date, and TB follow-up worksheet status. Next slide, please. The alien search section at EDN allows EDN users to view and print, allows EDN user to search for an arrival's medical record via any of the fields in the screenshot above, including the NTIP ID. Next slide, please. The batch print report section allows EDN users to view and print the medical records of multiple individuals at one time. Next slide, please. And our report section allows the EDN user to generate a PDF of a list of arrivals to their jurisdiction or jurisdictions. It also allows users to generate a blank TB follow-up worksheet and to access specific activity reports as outlined above in this screenshot. Next slide, please. The data download section allows the EDN user to download an individual or list of arrivals medical records in an Excel workbook format, and that information can then be further sorted in that Excel file via the sort and filter command. Next slide, please. The contact section allows the EDN user to search for names, contact information, and titles of individuals via state health department, local health department, or other views in each jurisdiction. Next slide, please. And lastly, the help section in the EDN system provides a variety of useful documents and webinars that users may want to take advantage of to further explain the features of the EDN system, as well as define the variables that they see in the worksheets that they complete for the TB follow-up worksheets or DS forms. So users can contact the MINX unit at minx@cdc.gov if they have questions about any missing chest x-ray files, missing EDN records for US arrivals, difficulty submitting a TB follow-up worksheet, medical or identification discrepancies on EDN records, EDN system access and training, as well as any address updates that they have on US arrivals. Next slide, please. And as a result of improvements to the electronic transfer process, including eMedical as well as IOM's MIMOSA system, pictures and chest x-rays are available for all US arrivals coming in from IOM. And they're also available for many US arrivals coming in from eMedical based on the electronic process. So as of mid-December 2019, we started receiving phone numbers from CBP, which reduced the challenge of locating people. And the document list may include photos of the individuals, chest x-rays that range in size between 3.5 megabytes to 5 megabytes, compression ratios provided. It also includes, may include panel reports for the individual, like syphilis, gonorrhea, sputum test results, etc., and phone numbers directly from CBP. There may be other documents available in the document list besides the ones that you see here in bulleted points on the screen, depending on how much information the panel physician wants to attach to this individual's record. Next slide, please. The Interjurisdictional Transfer Protocol document, which is located in the health section of EDN, details how to initiate transfers between states based on screening status and best practices to obtain contact information for an EDN arriver or transfer. So when a patient moves from state A to state B, per the Systems of Records Notice, also known as a SORN, which we abide by, state B will now own that patient's data, and state A will no longer have access to that patient's data. However, state A may securely send additional information to state B regarding the patient's data if needed, and more information may be accessed in the help section of help link of EDN. Next slide, please. I thank you for your attention to my presentation. If you have any questions, please do type them in the Q&A box below. And I will pass the mic on to Phil.
Okay, thank you very much, Amanda. How is my audio? Can you hear me? Thank you. Okay, yes, and yeah, thanks so much, Alicia, for hosting today, and to the Curdy Center for coordinating, and to all the participants for joining today. I wanted to talk today a little bit about the evaluation of immigrants with B notification for tuberculosis in California, what our experience has been like. I have worked with a TB program for the state of California for a number of years, and have worked pretty closely with partners at CDC and with the partners at local health departments with this system. And I just wanted to note again that the screening process is a two-part process. You can see on the slide here the overseas medical examination, which Amanda has spoken about, and I want to focus in on the follow-up TB evaluation experience specifically in California. So I'll describe some characteristics of Class B arrivers in California and what's specifically being done from a more practical kind of perspective to do the follow-up evaluation. And then there's been a lot of interest more recently in prioritizing Class B arrivers. Specifically looking at, are there some Class B arrivers who are more likely than others to progress to TB disease? Next slide, please. So as I mentioned before, there's the two-step process, the overseas medical examination, and then the US follow-up evaluation. And these are both, intended to prevent the importation of infectious TB among immigrants and to mitigate its impact when it does occur. And so panel physicians that are recruited by the International Organization of Migration and by CDC work at the sites, panel sites around the world to do this screening. And then the second piece, the U.S. follow-up evaluation, is carried out by U.S. state and local health departments, and we're all notified through the EDN system of people that are at who have a classification for a TB condition that requires a follow-up evaluation in the U.S. Next slide, please. So on the left side of the screen here, I just wanted to highlight that the technical instructions that are developed by CDC and with cooperation by IOM are very clear about the instructions for conducting the overseas medical examination. And at all the panel sites around the world, the steps are the same for persons who are seeking to resettle permanently in the United States. But when somebody arrives in the U.S. or in California, there's decision making that's kind of in the hands of the state and local health departments. And so on the right side of the screen here, I have the joint guidelines that are used in California between the State Department of Public Health and the California Tuberculosis Controllers Association. I have web links here on the slide as well, and anyone can access these guidelines, and they offer practical kind of clinical recommendations for making decisions about whether to do a repeat chest X-ray, or if someone has an abnormal repeat chest X-ray, what the next steps might be for follow-up. And these are updated periodically, and they were updated most recently. Actually, it was 5 years ago. It was in 2015. So these are available for anyone who is interested. Next slide, please. And this slide, I just wanted to emphasize again, you can see on the right-hand side of the slide, there are specific instructions and technical instructions during the overseas exam based on the applicant's age. If they're 2 to 14 years old, you can see the steps outlined there in red, and then on the right for applicants who are 15 years or older, what's done, and then just reemphasizing that there's less of a structured process for the follow-up evaluation in the U.S. The next slide, please. Next slide, please. So this slide is for about a 10-year time period. What we've seen in California, we receive about 6,600 Class B arrivers per year, and they are in basically two groups. There's those who arrive with a Class B1 classification, indicating that someone underwent an exam for tuberculosis and they had an abnormal chest X-ray that was consistent with TB. That's the largest group that we see and highest priority for completing the follow-up evaluation. The other group are the arrivers with a Class B2 LTBI classification, and these are persons almost exclusively who are 2 to 14 years old and who had a normal overseas chest X-ray, but had a positive interferon gamma release assay, or IGRA, whole blood test for TB, and they're also recommended for a follow-up evaluation in the U.S. And then you can see in California that the arrivers originate from one of 5 countries, almost half originate from the Philippines, followed by Vietnam, Mexico, China, and India. And I think if you click on the down arrow, there should be some animation that appears on the screen. Thank you. Okay, next slide, please. And so on this slide, I just wanted to emphasize the importance of the follow-up evaluation among Class B1 arrivers, the arrivers who have an abnormal chest X-ray and the overseas exam. Over this, roughly 10-year time period, we consistently see that approximately 1% of Class B1 arrivers are reported with active TB disease shortly after their arrival in the U.S., so within 6 months. And here you can see the number and then the rate among this group of arrivers. There's a slight downward trend here, which I tried to include with this dotted yellow line, but it's been pretty consistent over the last 10 years or so. So next slide, please. Okay, so getting specifically to the follow-up evaluation, what exactly is being done? On the next slide, I have a flow chart here and a bunch of numbers, but showing over roughly, again, a 10-year time period, what specifically is done with the follow-up evaluation with Class B1 arrivers. So first thing I would just note is that we've had, there's a high proportion and by evaluated, I mean that the person in their EDN follow-up worksheet were assigned a final ATS classification in their disposition or diagnosis section of the worksheet. And so among B1s, you can see that 93% had a repeat chest X-ray done. That's something that probably many of you are familiar with the follow-up evaluation work that you're doing with Class B arrivers. But what might be more surprising that we've seen over this time period is that among arrivers who had a repeat chest X-ray, that 38% had a normal chest X-ray. These are all people who had abnormal chest X-ray consistent with TB, were cleared for travel, and they had basically 3 months to travel to the U.S. 38% found to have normal chest X-rays. So that's raised the question from local health departments, programs that have said, well, do we really need to collect sputum and do lab work if the chest X-ray is normal? And what I wanted to emphasize in the data here, among arrivers where we have sputum culture results reported, this is an EDN, and it's only 20%. We did find 11 people who over this time period were reported in with the report of verified case of tuberculosis, RVCT, with active TB disease. So to answer that question, should we collect, sputum if somebody has a repeat normal chest X-ray? Based on our data, the number is, very small, but it's not zero. It was about one person per year who developed active TB disease. And then in the next group over here, the group where their repeat chest X-ray was abnormal, you can see in the middle of the slide there, the 60%. There's a larger percent of those people where we do have sputum culture results reported in EDN. And then when we look at the data in RVCT, we see there was 1.9%, so 109 people. And this is kind of falls in line with the data that I showed on the previous slide, that we've seen consistently about 1% to 2% of Class B1 arrivers, within a short time after their entry in the United States are reported with active TB disease. So hopefully this is helpful in trying to answer that question about whether to collect sputum if someone has a normal based on their U.S. chest X-ray result. So next slide, please. Okay, thank you. And so then on this slide, my colleague Amanda Dahm had mentioned that DGMQ partners with Division of Tuberculosis Elimination. And so what you're seeing here, and many of you may be familiar with this, is the NTIP program, National TB Indicators Program, and you can pull up for your program at the local level or at the state level indicator data. In this case, we're looking at Class B1 arrivers who were evaluated within 120 days during a 5-year time period, 2015 through 19. And so I mentioned previously that in California, 69% of Class B1 arrivers were evaluated. What was missing from that is this time window, this 120 days. So that, as of about 2 years ago, was added by DTB, and it is used in their funding formula when they're determining, funds to allocate to state and local programs, or to state programs for doing this work, this follow-up evaluation work. I also wanted to note that, when that time window, that 120-day time window was extended to 180 days, that's where we see California, the percent of Class B arrivers evaluated go up to 69%. So just emphasizing that follow-up evaluation work, as many of you are aware, requires oftentimes more than 120 days, to complete the follow-up chest X-ray. That may happen, relatively soon after the notification appears in EDN, but collecting sputum and doing lab work may well take longer than that 120-day period. So, but NTIP, just want to emphasize, very useful tool for monitoring Class B arrivers in your program, and you can gain access to this by contacting DTBE and be able to look at trends and data for the follow-up evaluation of immigrants and refugees in your program. Next slide, please. Okay, on this slide, I wanted to share a care cascade for Class B arrivers. We've found this as a really useful tool in monitoring our evaluation data among Class B arrivers. This is for a 5-year time period, 2014 through 18. It's a little different than what I showed before. Just a couple of points I want to highlight. Just that, despite the really high number of Class B arrivers that we see in California, here you can see during this time window, 62% have been evaluated and reported in EDN. So just highlighting the large amount of work that local health departments are doing to get these Class B arrivers evaluated. A third of those evaluated are found to have latent TB infection, which I'm going to talk a little bit more about in subsequent slides. And then among those who found to have LTBI, 44% were started on treatment. Among those who started treatment for LTBI, about half, 51% completed treatment. So just emphasizing, one, that that there is this high percentage of Class B arrivers who have TB infection, and we know that in California, about 80% of all the cases that are reported active TB disease are thought to be reactivation, people reactivating from TB infection to active disease. But then also emphasizing that it's a lot of work to get people who have TB infection started on treatment and to complete treatment. So next slide, please. So it gets to this question, in the last few years, there's been a lot of interest in short course treatment regimens for LTBI. And thanks to DGMQ and the folks that are coordinating EDN, we're now able to report this back. And so I'll share that with you on the next slide. So this slide is for a time period 2014 through September 2018. And I did this because this is right before a new question was added to the EDN Follow-Up Worksheet where the specific LTBI regimen is indicated. But what I did during this time period is I looked at the time window from treatment start to treatment complete for Class B arrivers who had LTBI. And there's been this upward trend, not surprisingly, with increased interest and use of short course treatment regimens. Next slide, please. This is the EDN Follow-Up Worksheet, which is now 3 pages. And you can see on that last page, I just wanted to note there's this question now where the specific LTBI regimen is noted. And on the next slide, I'll show you data for that for 2 years. So this we're really excited about because we're able to look at all the Class B arrivers and say that 76% were treated with a short course regimen, either 4 months of rifampin 4R or 3 months of isoniazid plus rifapentine. And then you can see the other treatment regimens that are here as well. And this is, we have about almost 650 people now are able to report this back out. And then we're, this is for the whole state, California, but we're able to look at the local level and see what types of regimens are being used. So very excited about this. So thanks to DGMQ for adding this question. So next slide, please. So this gets to my last topic I want to talk about is Class B prioritization. So we've gotten questions from local health departments who are interested in knowing if there's a way that someone, well, just specifically, are Class Bs all sort of the same as far as their risk progressing to active TB. And so some programs, local programs, have transitioned to doing a review by phone and just screening people to be able to see really early if they have a chest X-ray that looks really concerning or they are symptomatic, while other people who have a Class B could maybe wait until their cultures come back. So what we did, and this is a project that's still in progress, and I can show you on the next slide here, is looked at some characteristics that appear to be, there was an association with case occurrence. And this is over a 10-year time period. And found that when we look at gender, age, the TB incidence in the arriver's country of origin, whether they had a history of TB treatment, and their diabetes status, we could maybe use that to create a prediction or a prognostic score to help local health departments kind of zero in on what we think are the highest risk Class B arrivers for active TB case occurrence. Next slide. This table just shows the frequency number and percent, some of the characteristics I mentioned on the previous slide, age, the TB rate, and the country of origin. You can see in California, disproportionately, 58% of Class B1 arrivers are originating from countries where there's a rate of TB that's 150 cases per 100,000 or greater. History of TB treatment and the diabetes status on the bottom. And I think diabetes status, this is a self-reported variable, and that I was anticipating that might be higher. So it may be related to underreporting of that. But next slide, please. So here I took those characteristics. I did a univariate analysis, and then I put them into a regression analysis and did a proportional hazards analysis, and found that, of these over 9,000 Class B1 arrivers, that there actually were this much smaller number, roughly 1,500, that when we assigned a weighted score based on their, characteristics, the ones I mentioned in the previous slide, if you really had limited resources and staffing to do the follow-up evaluation work, this is one strategy that could be used to identify, persons who are, maybe more likely of developing active TB disease, and then prioritize them for follow-up evaluation. And these are based on methods that were developed by Ed Gravis and others in Texas, and they developed a prognostic score, but they were trying to predict tuberculosis mortality. In this example, I'm looking at case occurrence among Class Bs, like I mentioned. So next slide, please. So this brings me to my last slide. We're continuing to use the EDN system as a surveillance system to really try to maximize the completion of Class B follow-up evaluation, and to assist local health programs at the state health department level to be able to do this work. And I mentioned we're really interested in monitoring the short course LTBI treatment regimens, and the prioritization scheme for Class B follow-up evaluation is another area that we're continuing to work on, and we're hoping to operationalize that soon at some of the local health departments who have requested this. So I just want to say thank you again to our hosts and coordinators at the Curry Center, and Alicia, and then to all of you who participated today. I hope the information I shared is helpful. If you have questions, please type them into the Q&A box, and we will respond to them at the end of the webinar. So thank you very much.
Hey, everybody. Thanks for joining me in reviewing this Class B1. So I'm Heidi, and I'm the TB controller in Oregon. Next slide, please. So just a quick review of Class B1 and what's done overseas. So basically, Class B1s are adults who are over 15 years of age with an abnormal chest X-ray. That's what a B1 is by definition. They did not have a TB skin test, quantiferon test, or T-spot test overseas. And as of May 2020, there should be a digital chest X-ray image in EDN for B1 waivers. If the person was symptomatic for TB, or the chest X-ray was abnormal, or they were HIV positive, overseas a sputum is collected, 3 of them, and a smear, culture, and susceptibilities would be done. Of course, the susceptibilities are only done overseas if the culture is positive. Now, if all the cultures are negative, the applicant can go on and move on to the US. But if the applicant has TB disease, they're going to be treated with DOT overseas prior to being able to immigrate. Okay, next slide, please. So this is our case today, and I have to admit, this is a very simplistic case. So JG is a 68-year-old female arriving from the Philippines. You receive notification by email that her information is available in EDN. You review the paperwork, and I put paperwork in quotes because it's all electronic, and immediately you feel overwhelmed. Why is there so much information? This is kind of a typical response. So what should you look for specifically in the paperwork? Go ahead and think about this a little bit and put it in chat. Throughout this presentation, I'm going to ask you to put things in chat. And the idea of this is so that you can see what other health departments do, because a lot of times there isn't really a right way to do this kind of stuff. So go ahead and put this in chat. I'm not going to respond to it. It's just so others can kind of see how you would proceed. I'll give everybody a few minutes here. Okay, I'm I'm noticing in the chat that it seems like some people are only responding to the panelists. Please try to make sure that you're responding to everyone. I think that way the entire audience is going to see your response. So try to make sure that you're responding to everyone. Okay, next slide, please. All right, so reviewing the EDN paperwork, like I said in quotes. First thing you want to look at is, where is she now? Is she in your jurisdiction? Once in a while, you'll get somebody that's not in your jurisdiction, and of course, you don't want to follow up with them. You want to move them along. Is there a phone number? And just ask yourself, how are you going to handle confidentiality if the sponsor answers? So what is the chest x-ray? Is it consistent with TB disease? What are the sputum smear and culture results? Were either positive overseas? Was she treated for TB disease due to this medical evaluation? If yes, was the treatment adequate and given by directly observed therapy? And does she have a history of being treated for TB disease? If yes, is it well documented? So sometimes in the EDN paperwork, you will see that people had a history of TB treatment, but maybe it was long ago, like say 12 years ago. And when you review it, you see that it wasn't really a regimen that you might have used. So, you might not really even take that into consideration. It all kind of depends. These are very case specific. All right, next slide, please. So back to JG. Looking at her paperwork, the sponsor appears to be a relative. There's a valid address and there's a phone number, and the address is in your jurisdiction. She's a class B1. So the chest x-ray is abnormal. There's right upper lobe infiltrates, and that is very typical for TB. The image is in EDN, and you see that the overseas sputum smears were -3 and the culture was -3. So very smartly, you decide to call the patient. What will you tell her when you call? And you can go ahead and put that in the chat. And what would you do if there was not a valid address or phone number? Go ahead and put that in chat as well. And again, remember to put your response in chat to everybody, to everyone, so that the whole audience can see it. All right, I'll give everybody a couple seconds to put some info in chat. Great, I see a variety of responses. Some people go right to a home visit. Other people do recommend other things like mail, so great. Phone call, excellent, excellent. Okay, next slide, please. Okay, so here's what we decided to do in this situation. We gave her a call. So over the phone, with Tagalog interpretation, you explained to JG that because her chest x-ray is abnormal in the Philippines, you would like her to come to the clinic. You tell her you're concerned for her health and the follow-up is important. And you say that the appointment and any medications will be free. Now, I understand this might not be the case in every jurisdiction that you could provide everything for free. I think it is the ideal, though, because you're asking this person to come in for a public health purpose. So hopefully there's a way you can provide it for free or no cost. I think you'll have better adherence to your recommendation that way also. So JG asks you if she will be sent back to the Philippines if she has TB disease. And you tell her no and explain the appointment at your clinic is not required for immigration. Chest x-ray and test results will not affect her ability to stay in the US. And that's the truth, it won't. And so I think it's important that we make sure the patient realizes that. We don't want them to be living in fear or think that they might get deported if they have TB disease or, fear us. So I would explain that to her. Over the phone, you ask JG if she has a cough, fever, night sweats, or any other unusual symptoms. She states she's tired, but no other symptoms. And of course, being tired is understandable. She just came from the Philippines. All right, next slide, please. All right, JG at the clinic. So you tell her to come on in. You meet JG at your clinic. What needs to be done? You can go ahead and put that in chat. Does your health department offer clinical services for B waivers? Or do you refer all B waivers to a nonprofit, federally qualified health center, or private sector clinic for follow-up? Again, go ahead and put that in chat so the other participants can see what you do. And again, remember to put it to everyone so the whole audience can see. Okay. Refer for chest x-ray, QFT, I see. QFT, chest x-ray, sputum collection, QFT, repeat chest x-ray, IGRA. First of all, I'd meet her, start a good relationship. All very good answers. I love it. Excellent. So a good variety of responses. So great. Like I said, that's kind of what we expect. People are doing things different ways. Okay, next slide, please. All right, so JG at the clinic. In this particular situation, I think, did we go forward too much? Yeah, there we go, JG in the clinic, okay. Great, you do not have a physician available to review the overseas chest x-ray. Your protocol is to send the patient for a new chest x-ray and ask the radiologist to compare and read the image from the Philippines and the new chest x-ray. In your clinic, would you place a TB skin test, quantiferin, or T-spot test during this visit? Go ahead and put it in chat. And in your clinic, would you also start sputum collection at this visit? Go ahead and put it in chat. Good. I see a good variety of responses. Good, good. QFT and collect sputum, QFT, nothing, IGRA, excellent, excellent, excellent. So lots of different practices. Very good. Okay, next slide, please. Okay, so the results of the IGRA and chest x-ray. So we decided to just go with an IGRA and a chest x-ray. You obtain a quantiferin test during the visit. JG's quantiferin test is positive. The radiologist reads the overseas chest x-ray as abnormal with right upper lobe infiltrates and the domestic chest x-ray as normal. Again, put what would happen in your clinic. Go ahead and put that in chat. So we did a chest x-ray comparison, domestic chest x-ray normal, and the overseas was abnormal. Now, I think one important thing to note, and Phil mentioned this, is sometimes an overseas chest x-ray will be read in the US as normal, or sometimes the overseas chest x-ray is just really poor quality. If your clinic has a physician who can read the overseas chest x-ray first, or even better, a radiologist, that might save you some time and money, depending on how confident you are in that reading. Maybe you don't even need to have the patient have a return or a repeat chest x-ray. Kind of depends on how you feel about that. Also, you would, of course, save the patient some time if they didn't have to come to clinic. Okay, next slide, please. Lots of good answers in chat there, yay. Okay, JG follow-up. You review everything with the health officer or the physician you work with, or even the nurse practitioner, perhaps. She decides to treat the patient for LTBI or latent TB infection that says the patient is asymptomatic and her most recent chest x-ray is normal. So what latent TB regimens are best for this patient and why? You can go ahead and put that in chat. And what might you do differently if the domestic chest x-ray was the same as the overseas chest x-ray? That is, the domestic chest x-ray had a right upper lobe infiltrate. All right, go ahead and put it in chat to everyone, please. I see lots of short course recommendations. Very good. Good, good, good. Good, yes. Some caveats on using the short course, so excellent, very nice. Okay, next slide, please. So, conclusions with JC. She starts rifampin 600 milligrams daily, and she's going to be treated for 4 months. So lots of you guys did recommend this treatment. The other options are INH and rifampin for 3 months daily. Or you could do 3-HP, that's INH and rifapentine, 12 doses once a week. So those are all really great options. And as lots of you mentioned, if you're going to use those short course options, you want to make sure that they're appropriate for that particular patient. Otherwise, of course, we still have INH, 6 or 9 months. And that's really good, you know, for if the person has some drugs that might interact with rifampin or rifapentine. So just something to keep in mind. The patient has a virtual appointment monthly to check for side effects and adherence to treatment. And I think lots of people are going to virtual appointments due to COVID. Just a thing to keep in mind though is, you know, we do need to be careful to check for hepatotoxicity. And one of those things that can be looked at for hepatotoxicity is jaundice. So that can be a little tricky with a virtual appointment, but just keep it in mind. And luckily, JC completes treatment and she completes it successfully. So yay, excellent work. This, of course, is the ideal situation in all respects, but very good. So what needs to happen next? You would fill out the TB follow-up worksheet, and it kind of depends on your jurisdiction. Some jurisdictions require that you follow it up as the process goes along. So maybe you'd fill it up when you get that first quantiferon result, or maybe you fill it out all at the end. It kind of depends on what your jurisdiction or your state TB program wants you to do. And then you go ahead and submit it in EDN. Now, when I do these, I like to look at the EDN tuberculosis follow-up guide for help with how to complete the worksheet. It's a little complicated. It's not overly hard, but you do want to make sure you're putting the right thing in the right box. So go ahead and take a look at that. So hooray, I know you all will do an excellent job. And again, I know this case was a little bit simpler than a lot of them. So next slide, please.
Yeah, thank you everybody for these great presentations. If you haven't already, go ahead and put your question in the Q&A. That is next to the chat button, and we are going to go ahead and jump straight into them. We have about 20 minutes to cover them. So let's start with this one for Amanda and Deborah. When a local health jurisdiction receives notification of a new arrival, are they required to complete? Is there any consequence to the refugee or immigrant if the follow-up is not done?
Hey, yes, I was just in the middle of typing answers to this question, but I think it'd be good to answer live as well. So yes, when a local health jurisdiction receives notification of a new arrival, they are expected to complete follow-up for this individual. As for consequences as to whether the refugee, if the follow-up is not done for the refugee and immigrant, per our colleagues in the Division of Tuberculosis Elimination, there is a recommendation that follow-up is completed within 120 days from their date of notification. And so as for consequences, there are not any, we're not going to come after you if you don't complete follow-up, but for funding purposes I think that our Division of Tuberculosis Elimination colleagues may be able to speak more to that. I know they're not in this webinar, but funding purposes would be the main consequence of not completing follow-up within that 120-day period.
So just to summarize, it's tied with funding for the local health department, but there are no consequences for the refugee or immigrant, correct?
That is correct.
Okay. So the next question is, why no QFT above 15 years old required for B1 immigrants? So I think, again, that is for you, Amanda.
Okay. Actually, I wonder if, Phil, do you think that this question would be more suited for you?
Oh, hi. Yeah, I mean, I can share what I know from our experience. I know there was a lot of interest in adding quantiferon for immigration applicants who were over 15 years old. back in the fall of 2018 when DGMQ was working to, and correct me if I'm wrong on this, to transition from the tuberculin skin test to an IGRA test at the panel sites. And so I know there was some months there where it looked like IGRA was going to be offered for adult applicants. My understanding is that there just the amount of resources like laboratory capacity that were required because of a high volume of applicants, that the priority was to switch the 2 to 14-year-old applicants from TST to IGRA. And mostly it's quantiferon that's being used, or maybe it's exclusively. And that adults, that's something that hopefully in the future will be added, because that would be really helpful for state and local health programs to know of adults who have LTBI or a positive IGRA test. So hopefully, I'm not sure if that answers it. That's what I know.
Thank you. Heidi, or any of the other panelists, do you have anything else to add to that?
No, I also think, somewhat concerning could be the volume of people who would come in. If everybody got an IGRA and it was, say, a lot of people were positive, that could be a problem for local public health.
Thank you. So our next question is, how does the TB reporting and follow-up process change for undocumented immigrants? Who would like to take that one? So I don't know if Amanda, if you wanted to cover that, about what does EDN not cover? I think that might be a good way of phrasing that, because I know EDN does not handle all migrants to the United States, and there are some visas that are not covered in that, such as tourist visas, and I think students. So anybody else that would not be covered through EDN, Amanda?
That is correct, Sherry. Thank you. So for undocumented immigrants, we actually don't track undocumented immigrants, so EDN wouldn't have their information in the system.
So I don't know if that answered the question for the person that asked it. If not, you can ask another question in the Q&A chat box, and we'll see if we can address that. So our next one is, when conducting repeat health assessments for refugees, if their first chest x-ray was abnormal and their sputum smears and cultures were negative, if their second chest x-ray did not change from the first one, do we need to order sputum smears and cultures, and why? Who would like to take that? Heidi?
Sure, yeah, I can answer it from a general point of view. I think it really depends on what the chest x-ray is and how indicative it is of TB disease. I would say for the most part in Oregon, we would probably recommend sputum collection for a patient like that, even if the chest x-ray is stable, just to be on the safe side, particularly if it's something like infiltrates or fibrotic scarring, because we don't want to accidentally start somebody on LTBI treatment if they have TB disease. So it's probably good to do the more conservative thing for the most part and collect sputum again. Now, that said, there might be chest x-rays that just have a very minimal abnormality on them. And in that case, perhaps you could skip the sputum collection, but I would certainly have a physician or your clinician look at that. I wouldn't make it just part of a protocol.
Phil, did you have anything to add on that? Anything different in California?
No, I don't have anything more to add on that.
Excellent. So we'll go on to the next one. How should NTMs, or basically, non-tuberculosis mycobacteria, their environmental mycobacteria, results be interpreted in terms of classification? So I think this is a question for Amanda. How should it be coded on the worksheet?
In the help section of EDN, there's actually a help document that we have that explains how NTM results are classified. So you can take a look at that. I believe it's called EDN EDN Help Guide, or EDN User Help Guide.
And I believe that would be, you'd be able to access that through the presentations. So if you haven't seen it already, there are links to the presentations in the chat, and then it can also be reposted because I know it's a lot of different things in the chat. So you can just click on that and download it, and you can go straight to the guide. So that leads to the next question. If the liquid culture result was positive and the solid culture was negative, how do we classify this case? So Heidi, did you want to take that one?
Sure. Yeah, that's really interesting. I guess you could call your lab and see what your lab is going to determine. I don't know how they would report that out. I think our lab would definitely report that out as a TB case. So, you know, if you have a positive culture in either media, that would be a TB disease case. So I think it would be categorized as TB disease, but you might want to consult with your lab. It's kind of an unusual circumstance, I think.
Anything to add from any of the other panelists?
This is Phil. I would agree with Heidi. With what I've seen in California, it would be reported as a case. But yeah, consulting with the lab would be advised.
Excellent. Next question is, can you let us know what are all the approved short course LTBI treatment for Class B1s? Amanda, are there any difference from like what is approved for short course LTBI treatment for B1s compared to other TB patients?
This is a question. If this person could email me, I could type it out in more detail. We do have, just because I would like to include some more answers. So if they could email me, that would be good at links@cdc.gov. That's M as in Mary, H as in Harry, I as in Igra, N as in Nancy, x@cdc.gov.
So if you can put your email in the chat, that way it would be easy for them to see. That would be great. And so in California and in Oregon, do you have anything that you do differently with these LTBI patients compared to other population?
We do not. We treat them like anybody else who has LTBI, basically.
And I think that one of the other questions kind of addresses this a little bit. It was about let me get to that, has to do with use of the 4-month, the 4-month rifampin compared to 3-HP. And I think that's for you, Phil. Is there a reason why that you use more of the 4-month of rifampin?
Yeah, I don't work directly with patients, but I can just say, having spoken with staff with local health departments, there's several programs in California where at one point there was a shortage of isoniazid, and they found that patients were tolerating the 4 months of rifampin well for LTBI treatment, and so they just started doing that and then continued with that rather than switching over to the 3 months of isoniazid and rifapentine. So that was one of the reasons, and I think cost was part of it too. And I don't know if there was an issue. I think that the person asked the question about whether there's an issue with a shortage of rifapentine. I know initially it took some time for that to become available, but I haven't specifically heard about shortages. But that may have been part of the decision-making process too. But yeah, I was surprised to see such a high percentage, in California, of programs that were prescribing 4 months of rifampin. But
I can respond to that a little bit too. In Oregon, we mostly encourage the use of rifampin 4 months daily because, again, there has been issues with getting rifapentine, and rifapentine can be more expensive. And at least in Oregon, a lot of insurers don't cover rifapentine, but they would cover rifampin. So overall, we encourage the use of rifampin 4 months for treatment for LTBI.
Thank you.
Excellent. Thanks. So the next question is, how can we access the digital images for US comparison? I believe that's a question for you, Amanda.
Sure. Yes. So a lot of our partners have used Easy DICOM or Micro DICOM online. We don't. So CDC actually doesn't endorse any specific viewers to view these chest X-ray images, but those two have been pretty popular for our partners. So again, this Micro DICOM and Easy DICOM, I believe, and you can Google those to view chest X-ray images.
This is Phil. I can just add to that a little bit. Yes, some of the programs in California have used both of those. They're free, but there's been some hurdles as far as getting through the information technology IT department getting it installed. But once installed, people are able to use it. Or if they're at a clinic where they're already using software to view DICOM images, of course, you can do it that way. And then, sorry to add, just one thing I want to add to that. Is it correct to say, Amanda, that all the overseas panel sites are requiring, or they're doing digital chest? They've switched from burning CDs to digital chest X-rays, unless the immigration applicant requests a CD. Is that correct?
That is generally correct. Yes.
Okay. Thanks.
Sure.
Thanks. Next question, is it advisable to close the case as lost to follow-up after 120 days? Amanda, what are your thoughts on that?
Sure. So that is up to the health department to make that decision. I would advise consulting with the TB control program manager or state TB controller of that particular jurisdiction or state. I can't give a definitive answer as to whether you should close out the case after 120 days. We have had, in our system at least, in our data analysis, we have seen some people who have taken longer than 120 days to follow up with patients. So I would say follow up with your local or state TB coordinator to see what the procedure should be regarding follow up and close out of cases for that.
So Phil, what is done in California?
Yeah, so we've advised local programs to kind of leave the record open unless they get specific information that they know they're not going to be able to locate this person, or the person's moved out of state. Well, in that case, it would be interjurisdictional transfer. But we to some degree kind of left it up to the local programs. Some do have a policy where after 120 days, if they sent a letter and made a phone call, or made a phone call and sent a letter and had no response, then they would close out the record. But that's been decided at the local level. So there's variation across local programs.
How about in Oregon? Anything different?
It kind of depends on the resources at the local level. If they are feeling very stressed and they have lots of other things on their plate, I recommend they close it at 120 days, just because it seems like another thing that they have sitting on top of their head that they have to worry about. So I would recommend they just go ahead and close it for the most part. From what I understand, the last time we checked, it is a little bit difficult to reopen them once they've been closed. I think you have to ask maybe the EDN help desk to reopen it. So that's something to take into consideration. Also, I know a lot of B waivers have to sometimes go back to their home country and return to the US at like a later date. And that's always another question that comes up. Should we close those? Yes or no? I generally will say, yeah, go ahead and close them, and we can try to figure out how to reopen it if the person does indeed come back.
Thanks. So next question is, when someone fills out green card paperwork and they arrive as a B1, what are the requirements? Do they have to do a new chest x-ray even though they were evaluated after arrival? So green card paperwork. Amanda, do you want to kind of discuss the difference between green card paperwork and a B1?
Sure. So regarding the green card paperwork, this is a good question to ask our USCIS partners about, as I'm not super familiar with that process. But regarding completing a new chest X-ray, even though they already completed it upon arrival the first time. It's up to the clinic to decide whether or not they want to do an additional chest X-ray examination for comparison purposes to see if this person has improved or worsened or is stable from the last time they had the chest X-ray, or sorry, from the first time that they had the chest X-ray completed upon arrival in the US. So it's up to the clinic. We'll leave it to clinic interpretation.
So Phil, I believe that California does a lot with the physicians that do the change and adjustment of status for the green cards. Is that something that you would be able to answer?
I can try. So the civil surgeons, as they're labeled by the U.S. Citizenship and Immigration Services, so they're physicians, oftentimes primary care physicians, that are doing the status adjustment. Somebody's going from being a visitor or a temporary visa holder to a permanent resident or a green card holder. And there are guidelines that are available. I'm trying to remember. I'm pretty sure it's at the DGMQ site, or it's available at the USCIS site. I'm forgetting. Sorry, but there's similar. There's similarities between those guidelines and the guidelines that we offer to, physicians that are doing the follow-up evaluation for Class B arrivers. But yeah, there is, there are guidelines, and so local programs will decide what they think's best based on the clinical picture and their evaluation of the person, whether they're a recent arriver with a B notification or whether they're somebody who's already in the United States or in California, seeking to become a permanent resident. So a lot of words. I don't know if that answers the question, but I think looking at those guidelines for the civil surgeons, the ones doing the status adjustment, and looking at those would probably be the best place to try to determine what specifically should be done during that examination.
Yeah, so people with the green cards, they wouldn't be going through the EDN system. Instead, it's a different set of paperwork that they do through civil surgeons. And it's a different branch of the government that has the requirements, if I'm summarizing that correctly. Anybody else have anything else to add?
Sorry, this is Phil. Yeah, that's correct. Is that, CDC's through Health and Human Services, whereas the Citizenship and Immigration Services, that's through Department of Homeland Security. So, right, and it's complicated, lots of acronyms, but there are similarities in that, the medical kind of piece of that as far as what's done during the evaluation. So,
and it looks like that in the chat, there is a link that may be helpful for people to look at if they still have more questions about it. And then there also looks like that somebody put down that for 2020 arrivals, funding will be provided even if they don't meet the 120-day deadline due to COVID issues. I don't know if CDC wanted to comment on that.
No, I think that's we will leave it at that. I trust Bob's judgment. We work closely with our Division of TB Elimination colleagues, and so they have mentioned that to us as well.
Excellent. Next, so you may have heard about rifampicin having some contaminants, and there's a question about the increased risk of cancer with rifampicin. Heidi, did you want to take that?
Yeah, this is a tricky one. So of course, there has been lots of discussion about this contaminant and what it really means. Again, I think that you have to kind of take it on a case-by-case basis and look at what your program, your state TB program, or your local jurisdiction is recommending regarding this. For Oregon, we pretty much just advise that the health department discuss the situation with the patient, and we came up with some guidance for doing that, and then let the patient decide what they want to do. Would they rather go ahead and take that drug anyway, despite what I interpret to be a very, very small risk for cancer related to taking that drug and maybe no risk at all? Or would they rather take, say 6 or 9 months of isoniazid. So, or nothing at all, patient decision. So lots of shared decision making on that issue. And I'd be happy to share the Oregon guidance with anybody who wants it. They can send me an email and I'll send it on to them.
So it looks like there is some additional links that will be useful for people to look at in the chat. And there's also a question about rifapentine being removed from the 340B pricing. Is that something that you have noticed as well, Heidi?
No, I haven't. But yeah, we purchase under MCAP. We don't purchase under 340B anymore. But it seems unlikely that it was removed. I don't know why it would have been.
And I know that NTCA, that there is a place that you can report pricing issues for drugs on the website. Okay, let me see what else we have because we are coming to the end of our time. So if immigrants do not have possession of their overseas chest x-ray at the time of evaluation, is there a way that they can, is overseas chest x-ray scanned at the time of evaluation overseas? Amanda, did you want to tackle that one?
Sure. So if immigrants should have chest x-rays available in the system if they, sorry, let me back this up a little bit. The digital copy of the chest x-ray should be available in the EDN system for immigrants. I'm not, could you repeat that question? I'm not sure if I understood it completely.
So let me get down to it. It had to do with the x-ray not being in their possession, and they wanted to know, is it scanned? So are all turned into the system?
Yes, it should be available in the system electronically. It'll show up in the document list of EDN in the person's record as a .dicom file, which you can open up via those free viewers that Phil and I mentioned that a lot of people to use.
Amanda, this is Phil. One thing I was going to ask is, so the digital chest x-ray image is available for all arrivers as of, I think you said this past summer, right? So if someone is looking up a record for someone prior to, say, May of 2020, I guess it depends on what the country of origin is, whether at the panel site, the digital chest x-ray process, I mean, it's in place for all countries now, but I wonder if this has to do with looking at a record for somebody from a year ago, in which case, there wouldn't be a digital image. Is that right?
That's a good point, Phil. Yes. So if this person can maybe clarify, they could also email Minx at cdc.gov. I did put my email in the chat. I know there's a lot of stuff going on in chat right now. I can put it back in again. You can email me and I will answer more thoroughly. But yes, Phil, that's a good point. If there are older records that they're referring to that didn't have that that chest x-ray requirement in place, that might be an issue that they're referring to.
Okay, thanks so much. So a big thank you to all of today's presenters. So I'm going to hand it over to Alicia now. There were 2 questions we did not get to. We'll see if we can answer them and type them out. But Alicia does have a couple other things to talk to you guys about. So let me go ahead and hand it over to her. Oh, and Alicia, actually, there's a question. How can I view the recording of this seminar?
Oh, thank you, Sherry. Yes, we'll be posting a recording of the webinar on our archived webinars page on the Curry website, and we'll send out an email to everyone when that recording is posted. Thank you again. This concludes our webinar today.